I now recognize Mr. Moran.
Thank you, Mr. Chairman, for this very valuable hearing today about Medicare Advantage. For background for our witnesses, I want you to know I represent the 1st Congressional District of Texas, where just over 83,000 of my constituents have chosen to enroll in Medicare Advantage plans. That's roughly 48.6% of Medicare eligible individuals in my district. As I travel through my district, which is very rural, I hear a lot of struggles faced by many in the Medicare Advantage plans. These struggles are not unique to my district, but they are exacerbated by the fact that I am in a rural community. That's why I think this hearing is very important today, so that we can figure out how to make the changes we need to make so that Medicare Advantage works appropriately when chosen by our constituents. The number one difficulty that I hear about is that providers are forced to navigate these prior authorization rules that are really unworkable, oftentimes that create delays or denials for medically necessary care. Continual prior authorization denials require, as you guys know, a significant amount of staff time to appeal the denials, which pull staff away from their intended goal of providing care. Dr. Miller, in your written testimony, you mentioned, quote, the significant administrative and documentation burden resulting in burnout as it relates to prior authorizations. From your experience, how might the administrative burdens associated with prior authorization impact the work of physicians and staff?
So I think prior authorization makes it harder to be a physician, but it also recognizes that physicians don't always make the right choice. I mean, I'd like to think that I do, or my colleagues, most of the time we get it right, some of the time we don't get it right. Having to resubmit paperwork, having to send in a fax, having to call someone and voice dictate, as one of my colleagues here mentioned, is nonsensical. The process, there's nothing wrong with having prior authorization as a process. Every other insurance market has that, whether it's Medicaid, whether it's the ACA exchange plans, whether it's employer-sponsored insurance. The only place that does not have prior authorization in a meaningful form is fee-for-service Medicare, until, of course, the introduction of a new CMS Innovation Center model recently. But prior authorization is something where we need to make it easy for clinicians and hospitals and other providers to get the data into the plan, make it clear what the criteria are at the point of care, and then automate approval. I know that other members had expressed concern about AI. We should use AI to make the process more efficient. If I can automate prior approval for a drug, a surgery, an imaging study, that is a win, and we need to make that the default.
Dr. Basil, you mentioned in your testimony items relating to the prior authorization issue as well, in particular about post-acute care, which generally results in longer hospital stays that are costly when the prior authorizations don't come through. I can tell you I heard from a number of my home health groups back in the district who shared stories where they were unable to provide care because the prior authorizations would have taken too long and they simply had to move on to other patients. I want to ask you, Dr. Basil, what impact does this have on the care patients desperately need, the costs associated with the care ultimately received, and what needs to change in this process to correct these issues?
So I would agree with the general themes kind of the day. It's going to be transparency and consistency. Consistency between plans and the transparency in how these decisions are made, so, and the repeatability of that decision every time. I totally agree with those. From a, you mentioned, home health standpoint, as a faith-based institution, we go ahead and send people to the appropriate level of care, and if that ends up getting denied, we just have to eat that. And so we've made the decision, from a corporate standpoint, that we're just going to go ahead and do the right thing clinically and let the rest of that sort out. But it is certainly an issue.
Ms. Maroney, I want to come to you on the last question because the issue of transparency was just mentioned, and I believe transparency is really one of the foundations for trust in any situation, but particularly here. We need more transparency for our beneficiaries, I think, to be aware of the potential supplemental benefits that are out there, accessibility of providers, potential prior authorization issues that might come up with respect to certain procedures. In your opinion, you mentioned in your testimony that you emphasized again that Medicare beneficiaries trust us. Again, I think trust and transparency are related. How might increased transparency in these areas that I mentioned and others from health plans to providers and beneficiaries ensure that plans are delivering the services they advertise to beneficiaries and that trust is delivered?
If I think about just supplementals, it would be great to have readily available public data specifically produced by CMS about supplementals and the utilization around that for all payers and all plans. So that as you're designing a unique plan in the future, you're designing it directly to the consumers and what their absolute needs are specifically. In addition, prior authorizations, you can publicize that data specifically on the plans and their utilization rates, and then put that in a system directly to beneficiaries to know who is offering improvements in this area to create competition and more choice for beneficiaries.
Thank you to the panel. Mr. Chairman, I yield back.